Welcome to the Deep Dive. Today we're tackling something pretty central to modern vascular surgery, how these alternative payment models are really changing the financial picture.
Exactly.
And our guide for this is the latest edition, the 10th, of Rutherford's Vascular Surgery and Endovascular Therapy.
Yeah, that's right. We're going to dig into how payment structures have evolved, especially, within Medicare. And this whole shift, it's fundamentally about pushing for better patient outcomes and, well, getting more bang for the buck in healthcare delivery.
Okay, so let's set the scene. Before 2015, Medicare had this thing called the Sustainable Growth Rate, SGR. Now, the name sounds okay, but I gather it could actually mean big reimbursement cuts. What was the problem there?
Well, the SGR was designed to control how fast Medicare spending grew. But the thing is, as more people got onto Medicare and needed more services, the SGR formula basically said, okay, we got to cut payments per service to stay on budget.
Ah, so across-the-board cuts.
Potentially, yeah. Pretty drastic ones sometimes. And to stop that from happening, Congress had to keep jumping in, patching it up, overriding the formula. It just created a ton of uncertainty.
Yeah, sounds like constantly putting out fires.
Yeah.
Okay, then in 2015, we get the Medicare Access and CHIP Reauthorization Act, MACRA. Huge bipartisan support, I see, almost unanimous. And important point, this wasn't part of the Affordable Care Act, right? Separate thing.
Totally separate. Yeah, the support was massive. And CMS, the Centers for Medicare and Medicaid Services, they laid out some pretty clear goals for MACRA. Think of it like a big strategy.
Oh, okay. What were they aiming for?
Well, first off, improving the health of the whole Medicare population, then making care better for individual patients, and crucially, lowering Medicare's costs, but by getting people healthier and making care more efficient, not just by cutting payments blindly.
Makes sense. Better health, better care, lower costs. Kind of the triple aim, right?
Right.
What else was on their list?
They also really wanted to push for better information sharing, between doctors and patients using technology. Empowering patients was another big one, getting them more involved in their own care through education.
And for the doctors and clinicians themselves.
Right. CMS wanted to get as many people as possible participating in the new system, the Quality Payment Program, or QPP. So they aimed for flexibility, transparency, making it easier to take part.
Okay.
They even talked about tailored support for different kinds of practices, like small ones or rural ones. And key for our chat today, they really wanted to expand these alternative payment models, or APMs. Oh, and also providing good, timely data back to providers and, keep tweaking the program based on feedback.
So this Quality Payment Program, the QPP, kicks off in 2017. That's the mechanism, the actual framework. And it's designed to reward the high-value, high-quality clinicians and, well, maybe penalize those not meeting the mark.
That's the idea. It creates financial incentives, a carrot, and maybe a bit of a stick to get clinicians focused on delivering better care and achieving better results for their Medicare patients.
How do clinicians actually get involved? Are there different ways to participate?
Yep, two main paths. There's the merit-based incentive payment system, MIPS we call it, and then there are advanced alternative payment models, or APMs. There are different roads, different requirements, different potential upsides and downsides.
Who actually had to jump in from the start? Was it everybody?
Not quite everyone. Initially, back in 2017, it was clinicians billing Medicare Part B for over, I think, $30,000 a year, or seeing more than 100 Medicare patients. If you hit those numbers, you had to be in either MIPS or an APM to avoid getting dinged on your payments later.
And those numbers changed.
Yeah, they bumped them up in 2018, went up to $90,000 in billing and 200 patients, so a higher threshold.
Okay, now here's the key question for vascular surgeons. In 2017, when this all started, were there specific advanced APMs, those EAPMs, ready to go for them?
And that's a really critical point. No, there weren't. In 2017, Medicare hadn't approved any advanced APMs, specifically focused on vascular surgery. So what happened? Pretty much all vascular surgeons ended up going down the MAPS path.
Right. Okay, so let's unpack MAPS then.
Yeah.
What's involved? How does it actually figure out these payment adjustments?
MIPS basically rolled several older Medicare quality programs into one bigger system. It looks at clinicians across 4 categories, gives them a score based on performance, and that score decides if they get a bonus, a penalty, or just stay neutral on their Medicare payments.
And what are those 4 categories?
They are quality, promoting interoperability, which used to be called advancing care information, then improvement activities, and finally, cost.
Okay, 4 buckets. And you mentioned data collection started in 2017, but the money part, the adjustments, Didn't hit until later.
Exactly. Data reporting started in performance year 2017, but the actual payment adjustments based on that year's performance didn't kick in until 2 years later, in 2019. Gave everyone a bit of time to adjust.
How were those categories weighted at the beginning? Did one count more than others?
Oh, yeah. Initially, quality was the big one, 60% of the score. Promoting interoperability was 25%, and improvement activities was 15%. Interestingly, the cost category, it was weighted at 0% for that first year.
0. Why was that?
They needed time, basically. Time to collect the data properly and figure out the best way to measure cost fairly. But, and this is important, those weights can change every year. CMS tweaks the formula.
Okay, let's go through them. Quality, what does that involve?
Quality basically took over from the old PQRS program, Physician Quality Reporting System. It's all about measuring the quality of care based on specific performance measures CMS came up with. There were like 300 measures available back then.
300, wow. How many did doctors have to report on?
They had to pick six measures that were supposed to be relevant to what they actually do in their practice.
Can you give an example for vascular surgery, something specific?
Sure. One example is the percentage of patients 18 and older having an infrainguinal lower extremity bypass who get prescribed a statin medication when they leave the hospital. Pretty clear, measurable thing related to vascular care.
Seems reasonable. But you hinted earlier there was a snag for vascular surgeons in bigger groups. What was the problem?
Yeah, this is a big one. If you're a vascular surgeon in a large academic center or a big multi-specialty group, often the group picks the 6 MIPS quality measures for everyone, not just the vascular surgeons.
Ah, I see the issue.
Right, so you might end up being measured on things totally unrelated to your patients, like quality metrics for knee replacements or depression screening, things a vascular surgeon doesn't directly handle day to day.
So your score is based on stuff you don't even do.
Potentially, yeah. And the Society for Vascular Surgery, the SVS, they've pushed hard to let vascular practices within these big groups report on their own specific measures, but so far, no dice. It's frustrating, and it might not really show how good the vascular care actually is.
Yeah, that definitely sounds like a system flaw. Okay, next category, promoting interoperability, or PI. What's that about?
PI, which, yeah, used to be advancing care information, is all about using certified electronic health records, the EHRs, to engage patients and share health information electronically. It replaced the old meaningful use program, basically.
So, using tech for better communication and coordination.
That's the goal. You meet the requirements by showing you're actively sharing things like test results, visit summaries, treatment plans with your patients, and, importantly, with other doctors involved in their care, using the EHR system to do it.
Okay. Then there's improvement activities. Sounds like rewarding efforts to just get better.
Pretty much. It's a newer category in NetPS. It gives you credit for doing things that improve how your practice runs, how you engage patients, or how easy it is for patients to get care. CMS has a list of over 90 different activities in various categories.
90. So lots of options. Give me a couple examples.
Sure, it could be things like offering more appointment times, like evenings or weekends, or participating in programs to manage the health of a specific patient group, like those with chronic vascular disease, or working better with other specialists, improving patient safety in your office, or even just doing internal assessments to find ways to improve. Lots of choices there.
Right. And the last one is cost.
Yeah.
How does that work? You said it wasn't scored initially.
Correct. Cost replaced the old value-based payment modifier. Now, this one's different because doctors don't report cost data directly. CMS calculates it for them using claims data.
So CMS looks at the bills.
Essentially, yeah. They look at the total cost of care for your Medicare patients over the year and also the cost of specific episodes of care, like a hospital stay. The idea is to measure efficiency. Even if your quality scores are great, if your costs are really high compared to others, it could pull your overall MIPS score down.
And when did cost start counting towards the score?
It came into the MIPS score in 2018, starting at a 10% weight. But then, for the 2019 performance year, it jumped up significantly to 30%. So it became a much bigger piece of the puzzle.
What kind of cost measures did they start with?
The first two big ones were Medicare spending per beneficiary, MSPB, and total per capita cost, TPCC. MSPB looks at the cost of a hospital episode, basically from 3 days before admission to 30 days after discharge.
Okay.
And TPCC is broader. It looks at the total yearly cost for all the Medicare patients attributed to you, trying to capture overall efficiency.
Have they developed any cost measures that are more, specific to vascular surgery procedures since then?
Yes, and that's been a really important step. CMS started rolling out episode-based cost measures. These focus on the costs tied to a specific condition or procedure. For vascular surgery, the first ones arrived in 2020. Measures for hemodialysis access creation, so putting in fistulas or grafts for dialysis, and also for revascularisation for lower extremity chronic critical limb ischemia. So, procedures to restore blood flow in legs with severe blockage. These are much more relevant for vascular surgeons, obviously.
Definitely seems more targeted. Okay, let's shift gears a bit and talk about another big type of APM. Accountable Care Organizations, or ACOs. What's the basic idea behind an ACO?
Think of an ACO as a team. Doctors, hospitals, other providers who agree to work together voluntarily to coordinate care for their Medicare patients. The main goal is high-quality coordinated care. It's about aligning everyone's incentives around managing patients effectively.
And the coordination part is meant to improve quality but also save money, right? By avoiding duplicated tests and errors.
Precisely. Get the patient the right care at the right time, avoid doing the same test twice, prevent mistakes that lead to complications or hospital readmissions, better care, lower cost.
How do ACOs get rewarded for doing that?
It's mostly through shared savings. If an ACO delivers high-quality care and manages to spend less on their patients than what Medicare expects, based on a benchmark, the ACO gets to keep a portion of those savings. It's a direct financial incentive for efficiency and good management.
Have ACOs been around a while? Any track record?
Yeah, they're not brand new. CMS started the Pioneer ACO program back in 2011 with 32 organizations. Some dropped out, but 19 were still going strong through 2015.
Yeah.
And in 2013, CMS reported that 19 of the original 32 actually did generate savings, earning about $76 million back collectively. So it showed the model could work, at least for some.
Sounds promising. But I imagine setting up an ACO isn't simple.
Oh, definitely not. They have real potential, but they are complex beasts to set up and run. You need significant investment upfront for data systems, for care coordinators, for just getting everyone organized.
Right.
And you typically need a strong base of primary care doctors to manage the patient's day-to-day, plus a really good electronic medical record system that everyone can use and share information through. Big organizational lift.
How do vascular surgeons fit into this? Especially if they're in a big group that joins an ACO.
Well, it's kind of similar to the MIPS quality measure issue we talked about. In a large ACO, vascular surgeons are usually a small fraction of the total doctors. Their specific procedures might not move the needle hugely on the ACO's overall quality scores or total cost compared to, say, primary care or cardiology managing chronic conditions for thousands of patients.
So their impact gets diluted.
They can feel that way. It makes it harder for their specific contributions to be fully seen or rewarded within the ACO structure. And that's a big reason why people started talking about developing APMs specifically for vascular surgery procedures, like for leg revascularization or aneurysm repair. Those would let vascular surgeons have more direct control and accountability for the quality and cost of the care they manage.
Makes sense. It really shows why specialty-specific models might be needed. Okay, let's talk about the role of groups like the Society for Vascular Surgery, the SVS. How have they been involved in shaping all this?
The SVS has been really active, actually, right from when MACRA passed in 2015. They saw the writing on the wall, that value-based care was coming, and they knew vascular surgery needed a seat at the table to make sure these new models worked for their members.
And they weren't starting from scratch, were they? Didn't they already have quality programs?
Exactly. They had the Vascular Quality Initiative, the VQI. That's a huge registry where surgeons were already tracking detailed data and quality measures for vascular procedures. So they had the infrastructure and the data already, which was a big head start.
How did they use that VQI data in this new MACRA world?
Well, their quality committee, the QPMC, took the measures developed and tested within BQI and worked to get them officially endorsed by the National Quality Forum, the NQF. That's like the national stamp of approval for quality measures.
Did they get any approved?
Yep. A good example is Measure 465. That's about using antiplatelet medicine correctly when doing a carotid endarterectomy. It got NQF endorsed, and then Medicare actually picked it up to use in the QPP. So a direct line from SVS VQI work into the National Payment Program.
That's significant. How else did VQI connect to the QPP?
The VQI itself became a MIPS Qualified Clinical Data Registry, or QCDR. That's huge because it means vascular surgeons can report their MIPS quality data directly through the VQI registry they're probably already using.
So it makes reporting easier and more relevant.
Exactly. It bypasses some of that reporting on knee replacements problem for surgeons in big groups because they can use VQI to report on measures that actually matter for vascular care.
And the SVS also got involved with those cost measures you mentioned earlier.
Absolutely. CMS and the company helping them develop these measures, Acumen, they specifically invited the SVS Quality Committee to listening sessions in 2017 about developing episode-based cost measures.
So they were asked for input.
Directly. And then in June 2017, a group from SVS committee members, practicing surgeons, spent 2 days in D.C. working with CMS and Acumen to actually help build that cost measure for revascularization for lower extremity critical limb ischemia. The dialysis access one followed, also with major SVS input.
Wow. So they were really in the room helping design these things. It shows how important that advocacy is. Okay, let's zoom in on the efforts to create a dedicated vascular surgery advanced APM. What kicked that off?
Well, the SVS leadership saw this clear shift to value-based payment and realized they needed to be proactive. So they set up a specific APM task force, the main goal: help vascular surgeons participate in models that would qualify as advanced APMs under QPP.
Why advanced APM specifically? What's the big draw?
Two big things. If you qualify through an advanced APM, you get a 5% bonus payment on your Medicare Part B services. Plus, you generally get a slightly higher update to your payment rates each year compared to those in MIPS. It's basically better pay for taking on more accountability.
So potentially more reward, but probably more risk too? What else was the task force trying to do?
A second goal was just to get everyone in vascular surgery up to speed on how these bundled payment things work. What are the challenges, the implications? If you start getting paid a lump sum for an entire episode of care, not just fee-for-service for every little thing.
Understanding the nuts and bolts. And who was on this task force?
They pulled people from all the key SVS committees, clinical practice, government relations, coding, quality. Wanted to make sure they had all the angles covered: clinical, policy, money, quality measurement, a broad group.
Why pick peripheral artery disease, PAD, as the first thing to build a model around?
Several reasons. One, it's super common. Millions of people have PAD. Two, it's expensive. Treating PAD costs the healthcare system billions, over $20 billion a year in the U.S., and that number is climbing.
So high volume, high cost.
Exactly. Estimates back in 2015 suggested 20 million Americans had PAD, maybe heading towards 25 million by 2030. So it felt like an area where a well-designed APM could really make a difference, both for patients and for costs.
Okay, so what did this proposed PAPM actually look like? How would it work?
The basic idea was, a patient has a revascularization procedure for PAD, like a bypass or a stent. That procedure acts as the trigger. Then, for the next 90 days, the model tracks all the costs and the quality of care related to that patient's PAD.
90 days. What kind of costs and quality metrics?
That's where it got complicated fast. They realized figuring out exactly what costs to include in that 90-day bundle was tricky. Imaging, follow-up visits, maybe readmissions, home health. It adds up. And on the quality side, they looked at process measures like, did the patient get an ABI test? Are they on the right meds? Did smokers get help quitting? And also outcome measures, amputation rates, mortality, how long were they in the hospital? Did they get readmitted?
Trying to capture the whole picture. But PAD involves lots of different doctors.
Right?
Right? Not just vascular surgeons. How does that complicate things?
Hugely. That's a massive challenge. PAD patients often see podiatrists, cardiologists, interventional radiologists, primary care docs, endocrinologists, plus maybe home health, rehab, wound care clinics.
Right.
So figuring out how to bundle the payment and hold someone accountable for the total cost and quality when care is spread across so many different players, that's really tough. Who manages the bundle? How do you divide the savings or the risk?
Yeah. Sounds incredibly complex to actually implement.
Yeah.
So where does that PAAPM effort stand now?
Well, the task force definitely ran into those complexities. Trying to sort out the cost attribution and get the right data systems in place takes a lot of work and resources, personnel time, money. So progress on getting a full-fledged PAAPM up and running has been hampered by those practical hurdles.
So it's stalled a bit.
You could say progress is slower than hoped, maybe. But the task force hasn't given up. They still believe a good PAAPM could really improve care and lower costs eventually. They're continuing to work on it, understanding the landscape keeps shifting.
Okay, so bringing this all together, it's clear this move to alternative payment models is a massive shift. What are the key takeaways for our listeners, especially vascular surgeons?
The big message from CMS is undeniable. They want to pay for value, not just volume. And APMs are their main tool for doing that. These models aren't going away. They're likely going to become even more common for vascular surgery patients.
And even though the goal is APMs, many vascular surgeons are still in MIPS for now.
Right. Because truly suitable, advanced APMs for vascular surgery haven't been widely available or easy to join. APIs is still the reality for most. But participation in QPP, one way or another, is crucial.
Why so crucial?
Because developing these vascular-specific APMs is hard work, and it's happening against a changing financial and political backdrop. But given how many Medicare patients most vascular surgeons see, staying engaged with the QPP understanding ATs, pushing for workable APMs, it's absolutely vital for the financial health of their practices long term.
So they need to stay involved.
Absolutely. They need to keep participating in developing these models, keep collecting data like through VQI, and keep proving they can deliver that high-quality care efficiently. It's about demonstrating value in this new system.
The future of how vascular surgeons get paid really seems tied up in making these models work. It's complex, no doubt, but essential to understand and engage with.
Couldn't agree more. Understanding the changes, participating actively, especially in shaping those specialty-specific models, that's going to be key for vascular surgery to thrive in the years ahead.
So thinking about all these complexities, all the different doctors and hospitals involved, what kind of innovative solutions out there might help smooth this transition to value-based care, especially in specialized areas like vascular surgery? It's certainly a puzzle with lots of moving parts to think about. Thanks so much for breaking all this down for us today.
My pleasure. It's an important topic.